And just for point of reference, pretty much the majority of these questions that we use for your thoughts here, that I'm using for your thoughts, these are previous board exam questions. And the NBRC does not really, the NBRC is not really concerned about schools that might be using like questions that did show up on a previous exam, because they rewrite these questions all the time anyway. And it's the same concepts over and over again, but they just find different ways to rewrite them. But this one definitely was from a previous board exam. Okay, so looks like all right, now I'm going to place this patient on BiPAP, because when you think about BiPAP after extubation, that would be somebody who was probably not doing that great, but you went ahead and extubated anyway. So that would be what's considered to be weaning in progress. If you had to decide to just go from intubation to the BiPAP. So that's not something that even is being suggested here. This is a 22-year-old with asthma, and this is a drug overdose case. Now, sedation is going to help to ensure that your patient is in synchrony with the machine and that they're not trying to hurt themselves or hurt anybody else. But this is a different situation that we have here. True, the word agitated shows up. But then you got to look at everything that's going on. Why do you think this 22-year-old asthmatic, or not necessarily asthmatic, but she's got a history of asthma. Why do you think this 22-year-old is agitated? She's agitated because she's ready to be extubated, and she can be extubated with no problem, because why was she intubated in the first place? Was she intubated because of trauma? Was she intubated because of some kind of anaphylactic response? Did she have a neurological problem? Did she go apneic? Think about all the indicators for intubation, and you see why she was intubated. She was intubated because she was not able to protect her airway. She was OD'd on heroin. So now, what did they do for her? They reversed the heroin and gave her Narcan. And Narcan usually gets the job done. And now it's been 24 hours later. There is no reason in the world that she should continue to be on this ventilator. Why does she need to be on the ventilator if her underlying reason for being intubated in the first place has now been resolved? So you got to think of it the same way. Like, if this was pneumonia, what if she has clear breath sounds and her x-rays are looking really good and her labs are really good? So that's that same kind of condition that we expect. You know, the underlying problem has been resolved, and then we can go from there. This is a short period of time to be on the ventilator. So if you were thinking she needs to maybe start weaning, how much muscle weakness do you think she has if she's only been on the ventilator for like 24 hours? This is not somebody who's been on the ventilator for over a week, and now their muscles might be a little bit weak because the ventilators are doing all the work mostly. This is a classic situation where they could have extubated her probably right after the Narcan started working. And that happens a lot of time in the ER. So you'll go through all the trouble of intubating, getting them secured and getting them on the machine. And then they give Narcan, and now the patient is like a wild horse, like trying to extubate themselves, and because they don't need to be intubated now that they don't have the Narcan, or they don't have the drugs in the system anymore. So then you would just turn around like maybe the next hour or so and extubate. It happens a lot in the ER. It's just that this case, they decided to just keep her on for a 24-hour period for whatever reason. Not sure why, but she probably really didn't need to be on, but just maybe a couple of hours at that, maybe just an hour. Okay, so that's the whole thing about these kind of questions. You've got to just look at everything, and you got to ask yourself these fundamental questions. And then you got to answer those fundamental questions. Do you know your reasons for intubation? Do you know when you should consider extubating? Do you know who needs to go through a slow, drawn out process of weaning, like a spontaneous breathing trial? Because you want to be sure that they can continue to breathe on their own after they've been extubated. Okay, now, let me check. I think somebody has a question here. No? Oh, okay, I see what's going on here. Okay. This is how you ended up where I think a majority of people saw the word agitated and automatically thought about giving some type of sedation. But again, this is a different situation. This is not someone who's really, really sick, who's now fighting the vent, and there's a lot of dyssynchrony, and now we need to consider giving them sedation. This was a completely different situation where she doesn't need to be on this machine anymore, and she's responding the way you expect her to. It's not going to be comfortable for anybody to be on this machine, especially if you don't need to be on it. Okay. So whoever got this board question, whoever took the test when this question was on the test, maybe they got it correct, maybe they didn't. Maybe they were thinking the same thing. Maybe they thought that they should have been recommending sedation, or maybe they had practiced enough. Maybe they had done enough reviewing and Kettering and everything else, and then they were able to kind of like pick up on those little nuances and kind of like pick up on the right words and look at the big picture, and maybe they arrived at the right answer. Okay. All right. So then I included this right here just to kind of give you some perspective. RTs are being hired to be case managers as well these days. You're going to be focused on like COPD and like lung problems, but a case manager who will be responsible for pretty much every component of the patient is usually going to be a nurse or a social worker. Now, what is case management? It's more like that interdisciplinary approach, meaning you got to work with all of these different others specialty areas, and you're trying to coordinate, you're trying to lower costs, you're thinking about how is this going to affect your patient after they've been discharged, as far as how many different services they're really going to need. Is their insurance really going to pay for all of this? And also, you're working with the physician, of course, to tailor the care plans so that you are making sure that Ms. Smith doesn't end up being in the hospital for way too long. You're trying to shorten her length of stay, or LOS as they call it, as best as you can, so that way it's safer that she be discharged earlier than later, especially when you're concerned about hospital-acquired infections or nosocomial infections. And there's also going to again be a cost savings measure. Some hospitals or some insurance companies are only going to pay for so many days in the hospital, and that's it. So that's pretty much what case management is all about. I mean, so you may consider that avenue. Maybe you will start working at the bedside as a therapist, and then at some point, maybe you want to transfer over into case management if they have the opportunities at that particular hospital, or maybe they'll maybe another outside hospital is looking for a specific COPD case manager. There is only one person that I know of. I worked with her a little bit at Skyline. She works at UC Davis. Crystal, what's her last name? I forget her last name. It's on the tip of my tongue. But she is the go-to person for case management. She's a therapist, and she's been doing it for a while. And she goes and she does talks around the country. She helps hospitals set up a case management program and things of that nature. So she's kind of like the expert on it. And Skyline has an actual case management course in their bachelor's program, and she, of course, is the one who teaches it. And one of the courses that I was teaching, we had to collaborate on a lot of things. So it was kind of like two courses, but everything was all kind of like working toward the same case management aspect of it. I was on one side of it and she was on the other side of it. But either way, if you are in that role, you get to do a lot of good as far as you can help these patients save a lot of money. You can optimize their care, and you can usually persuade these other departments and get them to maybe make some changes, or you may make some recommendations, and then in the end it benefits the patient. All right, so just another avenue that you may want to consider or look into if that's something that will be interesting to you. Now, we go back and look at a normal lung spirogram and what it would normally look like. And of course, we have 3 volumes and 3 capacities. And by definition, a capacity would have to be 2 or more volumes added together. So like in the case of our inspiratory capacity, it's just these 2 volumes added together, the inspiratory reserve volume and the tidal volume. But normal tidal breathing, so this is just considered normal tidal breathing here. And so as we know, this isn't all that we can do. We can do more if we need to, especially in the event of like a fight or flight, or you just need to put in more effort, like you're gonna need to blow out a birthday candle or whatever the case is. You're gonna need to be able to take in even deeper breath, and beyond what you can do normally, that would be your IRV. So just this component right here from you took in a breath, but then before you exhale, you breathe in even deeper, then it'll just be IRV. So together, this is what our incentive spirometer is measuring. Let's pay. So on the IS, or the incentive spirometer, if Miss Smith is able to achieve 1,500 milliliters, then that's her inspiratory capacity. And that's how we coach her. We coach her to breathe in slowly and deeply, and then to do a breath hold at the end when she's up here, and then just exhale normally, back to her normal tidal. And then as you exhale, we know that there's more air inside of the lungs you haven't exhaled out. But if you continue to blow, so you exhale and then you push, you keep pushing until you get to the point where you can't push anymore, and that will be your ERV. And as we know, even beyond your ERV, there's still a little bit of gas that you can't get out, and that'll be your residual volume. So again, by definition, if you start adding these volumes together, then you're going to end up with some type of capacity. There's our inspiratory capacity, our vital capacity. This is when we were looking at the vein respirometer and we were talking about weaning. If you get your patient to do a vital capacity, this is what you're checking. You're checking to see the maximum amount of air that they can take in, because your vital capacity is only going to be as good as the amount of air that you can take in. So if you're say, like, look at your like IC, for instance. If IC is supposed to be this much, but instead it ended up being half of what it was supposed to be, you can expect your vital capacity to be normal. And this translates to muscle strength in a way, because in order to be able to take a deep breath, you got to have adequate muscle strength. And to be able to take a deep breath and cough effectively, you got to have good muscle strength. So if your vital capacity ends up being pretty poor, you're thinking maybe it's a muscle weakness issue that's related to that. Or what if it's a major air trapping problem? If there's air trapping, come on. So if there's a lot of air trapping that's going on, you could expect that the FRC is going to be way higher than it's supposed to be. And if the air is still in the lungs when you're trying to do a vital capacity, the machine is not going to be able to measure everything because some of the air is still in the lungs. So then that will lead to a vital capacity that's much lower than normal. And then, of course, the TLC is just that. TLC is looking at everything, every single volume that you have added together. Or they did a shortcut here and they said that it is the VC plus the RV. But then what is the VC? The VC is TV, or tidal volume, RV, and ERV. So I guess just to save space, they could have written it as VT or TV plus IRV plus ERV plus plus RV. But as we know, it's everything added together. All right, so this is the basis of the PFT test. The PFT test always starts, the complete PFT test for sure, it always starts with the vital capacity. They're going to ask the patient to take in as deep of a breath as possible and then just blow, 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 blow. So take in a deep breath, as deep as you can go, would be down here. And then blow as hard as you can. Blow as hard as you can. Keep blowing, keep blowing, keep blowing. And wait, I'm looking at it the wrong way. I'm sorry. taking as deep a breath as you can. Here's our starting point. There we are. So we're going to do our PFT, and we're going to have the patient take in as deep of a breath as possible. So then you go from normal tidal all the way up to your IC or IRV, and then you blow, 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 blow. And then once you feel like you don't have anything left, you keep blowing, you keep blowing, you keep pushing, you keep pushing, you keep squeezing, you keep squeezing, and a little bit of air will still be coming out. And that's what the ERV is all about. There's still a little bit there. You got to push it out hard though. And then when you can't anymore, then that is the end of your vital capacity. And then you go back to breathing normally again. So then again, PFT test is going to always start with that. And then from there, the machine is going to be able to determine some other things that's related to the vital capacity. Even at the bedside, when you do a portable spirometry or a little portable PFT type of test, it's the same thing. You're going to have to instruct your patient to do a vital capacity. And it's going to be a forced vital capacity. Okay, well, it looks like it's break time. So, what is it? So in 10 minutes, we'll